Welcome to JAMA Plus AI Conversations. I'm Dr. Roy Perlis, Editor-in-Chief of JAMA Plus AI and today's host. And welcome to our guest, Dr. Eden English, Senior Medical Director of Informatics for UCHealth and an Assistant Professor there. She's the author of Utility of Artificial Intelligence Generated Draft Replies to Patient Messages, which recently appeared in JAMA Network Open. Dr. English, welcome.
Thanks so much for having me.
In case any of the folks listening haven't read your paper, can you tell us a little bit about what PamChat is and how it works?
Sure. PamChat is what we call it locally at UCHealth, and it stands for Patient Advice Message ChatGPT. And what Epic is calling this now is ART, or Augmented Response Technology. So post-publication, we're actually switching over from calling it PamChat to ART. But essentially, this is just the generative draft replies in the in-basket for providers or staff to use for the patient messages.
Got it. So what does it look like? What does it feel like when someone's sitting there using this thing?
It's really simple. The tech is super simple on the user end. So the patient message is right there in your normal workflow where you see it. And you have the opportunity, if we're using this tech, to have a generated draft in line. So right in line, instead of creating an answer from scratch, you have this generated draft reply that you can look at, read, decide if it's helpful, decide if it sounds roughly like you would have answered the message yourself. And if it does, there's a button that you can click that says Start with Draft. And if you click that button, it pulls in the LLM's generated draft reply into your answer. And then the user still has full ability to edit that answer before it hits send. So there's nothing automatic happening from the LLM, but the draft is created and therefore the provider or staff or whoever's answering the in-basket message to use as much or as little of or none of as they want.
And I want to get into what you found in your study in a minute, but before we get there, how did this tool come to exist? What's the backstory of building it in the first place?
Really, there's been so much interest in LLMs and generative AI in general, but there's also been a ton of interest in how to help the burnout that we're seeing across the medical sphere. So providers are burned out, nurses are burned out, we're all struggling. And one of the big struggles that everyone reports in the ambulatory world is the in-basket. And our in-basket burden has just gotten huge in the last 10 years, but especially huge during the pandemic. So we went from a relatively small number of in-basket messages to a massive number of monthly in-basket message. I believe our volume increased by about 350% during the pandemic on the number of messages that providers are being asked to deal with every day. So everybody is really looking for ways to unburden the clinicians who are leaving in droves to try to keep them happy and healthy working and answering these messages and still seeing patients. So this was thought to be a great partnership that we can use ChatGPT and other LLMs like it to help take the edge off of the just vast number of messages coming to our providers. And so there's a partnership with Epic and OpenAI that are creating these sort of draft responses or helping organizations that use Epic implement this, where GPT is in a secure cloud, so it doesn't have access to the patient information to learn off of. Everything's HIPAA secure, everything's private, but it is fed to a secure place where ChatGPT can take a crack at answering the messages for us. And the whole idea is really to help with the in-basket burden and ultimately to help with the provider and staff burnout.
So one of the things I liked reading the paper was that you get into some of the iterations that were required and the sort of back and forth. Can you talk us through a little bit about that? What sort of iteration did you have to do to get this thing to work well?
That's a fun question. And every organization that's using this is really doing their own thing here. So it's interesting to see what everybody else is doing too. What most of us are doing is we have a group of prompt engineers or a few people in the organization that are working on the prompt. So what happens, just so you know, a little bit behind the scenes, is we send the message that the patient asks us to ChatGPT, to the LLM, but we also have to send it some instructions. What do you want it to do with this message? So we craft a prompt that includes our instructions to the LLM, plus the patient's message, plus whatever information we think is key from the chart. So patient's name, patient's allergies, patient's age, those kind of things we tend to include. And Epic has a starting point. They have a prompt library that we can access to see what other people are doing, and they have a general suggestion that everyone sort of starts with. And we run that as our prompt for a little while. And we have feedback from the providers and the users that are seeing this. And they have an inline button where they can click, they liked it, they didn't like it, and send us a little bit more feedback. And what we're doing at our organization is every 2 weeks, we take that feedback workbook of all of the prompts that were commented on by any user one way or another and look and see what they liked, what they didn't like, and any of their other thoughts. And then we behind the scenes have a little test environment where we can try editing the prompt that we send to the LLM to update it a little bit and say, okay, they didn't like it because the prompts were too long. So be concise. We'll add that to the prompt, or we'll change some other words to try to get it to be more concise. So we're updating the prompt in a test environment based on user feedback.
And how much iteration did you actually have to do? So what kind of process was this to get from what they gave you to what you decided was, I guess, not necessarily the final product, but the final product that you wrote about?
We are doing iterations almost every other week, and they're mostly minor. Mostly we're tweaking one line here or there. We made some pretty significant changes from the original Epic prompt. That said, Epic has also changed their suggested prompt in this time, so they're iterating just as we are. And GPT is also upgrading. So ChatGPT, the model that we started on, was 4, and now we're on 4.0. So upgrading that LLM behind the scenes also has huge upgrades to your output because the GPT model itself is fine-tuned. But we have been changing this almost every other week. We've made a ton of minor iterations. A couple of the really big ones that we found helpful were including the subject line of the message, which just seems like a no-brainer, but when we put that in, that made things a lot better. And then including the assessment and plan of the most recent progress note from a provider, that was really a huge lift in our output because it had a little bit more actual relevant information to work with. And then we keep sort of fine-tuning as it spits out something that's driving us crazy. We'll add another line that really tries to deal with that particular problem. So it's a little bit like whack-a-mole, but it's interesting and it's fun to see the outputs and sort of watch that feedback workbook every other week as people are really liking it or really not liking the adjustments we've made.
And you sort of alluded to this, but other than length, what are the kinds of responses that drive you crazy? Like, what are the things that you said we have to fix this?
We mentioned a couple of the hallucinations or confabulations in our paper too, and those are things that we're always trying to fix. And one of the things that we're struggling with right now is the vaccine answers. So we actually published this too, that initially with the GPT-4, when you asked it, should I get an RSV vaccine? It would say RSV vaccine is theoretical and that's not anything that we have for adults. The RSV vaccine came out in 23, so obviously that was not helpful. We were getting a lot of negative feedback. So we added a line to the prompt that said, if they ask about the RSV vaccine, say specifically this. But then when we upgraded or when they upgraded to GPT-4o, it had been trained on RSV. So we were very optimistic that this would work. And initially it did. And then in the last couple of weeks, that's not the question we're getting anymore. We're getting, should I get another RSV vaccine? And when left to its own devices, unfortunately, this now says, yes, you should get one annually. So we got a lot of feedback on that. And we've added another line that basically just instructs it to put in a wildcard or a placeholder for the provider to answer because it is not answering those vaccine questions correctly. It just doesn't have access to the most up-to-date information on when we should get RSV vaccines or when we should get pneumonia vaccines. So instead of letting it put misinformation in front of our clinicians, we've instructed it to just put a wildcard and force the provider to answer that particular question.
Got it. So all of this is operating on sort of the base OpenAI models. In other words, for this kind of work, you don't have fine tuning or other references or anything. You're taking kind of what the response is, and then I guess the clinician ultimately decides if it's something they want to give to the patient or not.
Correct. We have no ability to fine tune the model. We're beholden on OpenAI's fine tuning. And it's not linked to UpToDate. It doesn't have access to go search websites in real time. It only has the information that GPT-4o had when it finished its most recent fine tune. So all we have ability to control is what we tell it in the prompt.
It sounds like this is the sort of thing that's going to continue to evolve, right? Because every time they push a new model or frankly, the state of medical knowledge changes, new things are going to emerge. So is this the sort of thing where people using this kind of a tool are going to have, whether it's one person or a group that is in the background, making sure that things don't go awry over time?
I think that's one possibility. I think right now there does have to be a very hands-on approach, and especially as medical knowledge changes, we have to be very aware that the bot doesn't have access to that. So those are the things that we're paying a lot of attention to. But what I've seen in sort of the pipelines, and none of this is certain yet, but there's ways that this can get a lot better. There's potential for this LLM to be integrated with maybe other things like UpToDate. Not that I've heard that yet, but if it could be integrated with an actual medical website to search these kind of things. And then there's also a lot of work in the space of LLMs improving their own prompts. So there's work in sort of two spheres, with including a lot of patient examples to have better outputs for that, and then potentially having these models fine-tuned on medical information or potentially connected to medical websites to have better ability to answer. But for the short term, which with AI is really short, that might just be a month or two before we actually have some of these options. But for the short term right now, it really is a very hands-on manual process for a lot of us to watch what's happening with the outputs, check against actual current medical knowledge and medical best practices, and make sure that the prompt is not spitting out misinformation as much as possible.
You report in the paper that I think 12% of the messages that were generated were ultimately part of patient communications. Did that feel like a lot or a little or probably just about right? Is the goal ultimately that 80% get used in patient communication, or do you think 12% is still pretty good?
I think both. I think we would really want our percentage to be up in the 30 to 50% range. It's never going to be perfect. Patients ask some complex questions about medical history or what we just did that aren't going to be well answered by an LLM. But I think we can do a lot better than 12 or 15 if we keep working on the prompt engineering and all the other things we've been talking about. And then I also think that if you're talking about 180,000 messages a month, having a bot answer 12% of those is huge. So that can really unburden staff, even at what seems like a fairly low percentage. If you have a draft started for you, and especially for some of these multi-part questions that the patients send us, the LLM really does a good job of sort of queuing up a draft that has answered all of those parts and letting the provider or staff go in and edit whatever's necessary, but you don't have the cognitive load of really thinking through every single bit of the question because it's started for you. They've started a draft. So I think that having the start on even a low percentage can really be great. And I think that as this tech continues to improve, we're going to see much higher use rates.
What about the ethical context for this? So when you were setting up the project, designing the study, how did you think about handling, for example, disclosing to patients that AI was involved in the loop?
It's a really good question and a hot topic. And what we did from UCHealth is we decided we really wanted to be transparent. So we wanted to be as transparent as possible with the patients. And we made the decision that behind the scenes, when a user clicks the Start with Draft button, it pulls in a final sentence that says, this was automatically generated, then edited by whoever clicked that Start with Draft button. So we include transparency by default so that patients can see it. And now at the time of publication, that sentence is part of the editable thing. So the user sending the draft can choose to not be transparent. The organization's default is transparency is included, but not mandatory. We are about to change that just because we really do want transparency, and we see occasionally users not including that sentence. So we're going to change it so that the sentence is mandatorily in the messages that are sent so that patients have the ability to know that AI was involved in the draft. But the key thing for me is that then edited by user, because none of these drafts go out without an edit. It was the way it was built from Epic and OpenAI that there is no option to send straight to patient. Your best option is start with draft, and then you have to click another button to send. So there's always that pause between message generated by AI and being sent to a patient where a human user has to look at it and decide that it's okay to send. And then right now, transparency is included by default, but optional to be removed by the end user. And we're going to pull that optional piece out probably here soon. I think most other organizations are leaning towards transparency included or hard-coded.
So I didn't realize that there'd sometimes been an option not to include it. Did you hear anything from clinicians about why they might choose to delete it?
Lots of varying things, but the most common thing is that patients aren't going to like it if they know it's AI. And I don't have it at my fingertips, but I know there was a paper or something somewhere where if patients know AI is involved, they like it less. If patients aren't aware that AI is involved, they really do like the response. And that's what I hear from clinicians, that the responses are great. It's not AI because they're reading it and they're editing it. So it's not AI, it's them. And patients won't like it if they think AI was involved. So that's why we're hearing people are removing it. And we just think as an organization that transparency is important enough that we really want to put that as a mandatory rather than optional. And we've not heard complaints from patients that they really don't want this involved in their care at all. So we really are hoping to go with full transparency without an issue from our clinicians and staff.
That makes sense. What I also noticed was a discussion about the capacity for empathy, right? That responses had varying degrees of empathy. And I have to say that gives me the heebie-jeebies a little bit, right? The idea that the computer's telling us how to sound more human. What was your take on what you saw with empathy in these responses?
This GPT is nicer than most of us. It's more empathetic, and it's really that it doesn't take it any time. It's really all about time for me. It's not that providers and staff aren't empathetic and aren't nice and wouldn't love to draft a longer, very empathetic answer to most of the questions, but we're strapped for time. And so often when a busy provider is answering their 50th in-basket message of the day at 7 p.m. when they really want to be home with their children, they're just answering, sure, thanks, whatever. They're not putting the extra niceties around it that really make you feel connected. And ChatGPT or any LLM isn't busy. It doesn't get bored. It doesn't get tired. So it is always empathetic, even if the patient was a little rude in their message, which happens not infrequently. So it just is default empathetic, no matter how many messages it gets a day and no matter how rude the patient was. And when that's in front of us, we can use the empathy and still edit the medical text. It's not that we wouldn't want to say it or wouldn't say it if we had time. It's just a function of how much time we have to answer the many messages in our in-basket.
You sound enthusiastic. You describe the tool and you describe the study, and it's clear that this is something you've enjoyed and that you think is helpful. Do you worry about it? Do you worry that there are things we're not paying enough attention to that could impact patient care?
I worry that we need to keep sort of our finger on the pulse and we need to keep pushing the training. And it's tricky because this tool is so simple to use. So there's not training on how to use the tool, but it's really about just awareness that ChatGPT, LLMs in general, confabulate, hallucinate when you leave them to their own devices, which this does. So it will generate a response that is not medically accurate. When we roll out this tool to a new clinic, we talk to the medical director, we talk to the practice manager so that everyone in the clinic that might have access to these responses knows that there's a possibility that the draft in front of you is inaccurate. You are the expert in the room and you need to read it. And if you don't know what is in that draft to be true, then do not hit send. Send it to your provider to vet, send it to someone else to draft, write your own response, but don't trust this to be accurate because that's not what it's meant to do. It's really meant to generate a response and let you, the expert, decide whether or not to use it. And I think that there's always a danger that someone's not going to read what's in front of them, just the same way we might sign off on a med student note or anything else that's got inaccuracies because we're not paying attention. But it's that level that we really need to focus on is we need to pay attention to these. It can be a great tool. And it can make us smile. That was one of the things we saw in the paper too, that PamChat is fun to use was sort of agreed on by everyone, even the people that wouldn't recommend this tool to someone else. So if it can make us smile and we can get our hands around the training that everyone needs to know, this draft is coming from you. Once you hit sign, you need to read it carefully to make sure it's accurate. That really is the only thing that's concerning for me, that people are going to have some automation complacency and hit send without vetting it carefully. And we need to just keep pushing that if this tool unburdens you a little bit, you have to do the right thing and read the message in its entirety and make sure that it's right before you hit send. And otherwise, I think it really has potential to unburden us here and to help get these drafts started for us so that we can continue to interact with the patients in the way that they've become accustomed to, but without working late into the evenings creating all of these ourselves.
Well, I like the idea of a tool that makes us smile and keeps us from working late into the evenings. I think that's probably as good a place to end as any. I'm Dr. Roy Perlis, and I've been speaking with Dr. Eden English from UCHealth about AI-generated draft responses to patient messages. You can find a link to the article in this episode's description. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. This episode was produced by Daniel Morrow at the JAMA Network. Thanks for joining us.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.